Okay. Very good. Let me. Okay, everything is fine now. We are holding a session about the 10 tips on diagnosis and treatment planning on the endodontic treatment. And we are honored to have Dr. Awana Timmerman from Australia. And it's a great honor and pleasure to have her as our member. And she's going to give us an amazing and insightful lecture. And this is a great chance for all of us to learn from her knowledge and experience. Dear Vana, I want to start a brief presentation about yourself. I know everyone know who you are, but we are eager to hear it from you. And then we will start the session because I have received some message from Dr. Muzaffari and Dr. Atta. They are going to join us a few minutes later, but we have to hold this session on time because I know the time matters for you.
قیافش معلومیه ولی سیستمش وحشی‌تره. خیلی وحشی.
Okay, dear Vana, please start.
Okay, no problems. Welcome everyone to my webinar on 10 learning points in endodontic diagnosis and treatment planning. So I'll explain a little bit about my journey in dentistry before I start the webinar. So I did my basic dental degree at Melbourne Uni back in 2001. And then I proceeded with completing my fellowship with Royal Australasian College of Dental Surgeons 10 years later in 2011, before I embarked on my specialist training, and I completed that in 2016. And after I became an endodontist, I really enjoyed teaching, so I decided to do a graduate certificate in clinical teaching. So in 2019, that was just before the pandemic happened. And, you know, when the pandemic hit in 2020, I couldn't actually teach in the hospital because the hospital was closed during the first lockdown. So that was when I decided to share some of my cases, my clinical cases, on Instagram. And the intention was really to start sharing with my students at the time. But then, you know, later on, obviously, you know, I ended up having a lot more followers and then making connections with all of you endodontists in various countries. So that's very exciting for me. And then after finishing my, you know, certificate in clinical teaching, I then was awarded my membership in specialist practice with the Royal College of Dental Surgeons as well. So today, the objectives of the webinar is to identify ways that can help us to arrive at the diagnosis more effectively. A lot of webinars or lectures given by endodontists, I find, really focus on the technical aspects of endodontics. So that is why I wanted to give this webinar to look at diagnosis a little bit more, because yes, we can do very beautiful treatment, but can we actually arrive at the diagnosis more effectively? That's the big question that we should have. Because if we don't arrive at the diagnosis, a lot of problems can happen. And we also want to recognize factors that can impact on case difficulty. And we want to examine several clinical cases that are complex in diagnosis or treatment planning. And I would like to include some interdisciplinary cases as well. So first of all, why do we need a diagnosis? Okay, so if we don't have a diagnosis, we could be treating the wrong tooth, because a diagnosis helps us to arrive at a treatment plan for the patient. And then secondly, it helps us to communicate as dental professionals what the problem is and what the treatment is going to be. And therefore, it has a medical legal perspective as well. So in Australia, you know, we have some expectations for dental practitioners to document in the dental records definitive endodontic diagnosis using contemporary terms for both pulpal and periapical diagnosis. And we also expect the clinician to be able to collate the information regarding the patient's medical history, dental history, and pain history, together with the information from the clinical and radiographic examination, and also the information from the clinical tests as indicated to arrive at the diagnosis. Also, we expect that the clinician should be able to assess the case difficulty and to think about their ability and competency and what they have in their equipment and materials in order to carry out endodontic treatment. So with taking a pain history, I like to use a mnemonic. Okay, so I like using Socrates. I'm sure this is very well known. So first of all, we want to know where pain is coming from, when it started, what is the characteristic of pain, and where does it spread to, where is it, where is the location of the pain and where is it going to, and whether it's associated with any other symptoms. And also we want to know how frequent is the pain history, and also how long does pain last for. And we want to know what makes it worse and what makes it better. And we want to know how severe it is for the patient. So I'm going to start with a case, okay, Mr. JK. And this patient has been diagnosed with osteoarthritis and type 2 diabetes. And this is a 78-year-old patient who wears complete dentures for more than 10 years. And he has been getting constant dull ache in the mandibular area in the last, 2 weeks, especially on the chin. And he had a few situations with pain spreading to his left arm as well. So what do you think could be the possible diagnosis from listening to the patient about those symptoms? So could it be trauma from the denture, or could it be related to his osteoarthritis? So what ended up happening was that this patient was sent to his medical general practitioner, and he was diagnosed with ischemic heart disease. So this is actually from a case report, and it actually emphasized to us that sometimes when you have a patient presenting with orofacial pain, it may be actually related to something serious like cardiac ischemia. And, when we actually look at, say, some of the patient's symptoms, we need to also think about, what these symptoms could be potentially featuring. For example, this is just a list. I'll go through some of them. So say, for example, bilateral pain or multiple teeth with pain, pain that does not follow a neurological distribution, pain that's described by patient as burning, stinging, electric shooting, pins and needles. These are all quite unusual, or pain that has been chronic for a very long time and has been unresponsive to dental treatment. Okay, sometimes we have patients coming in and say, I've been in pain for 10 years, and that's really unusual. And pain that is not consistently relieved by local anesthesia. So all of these lists, we need to think about, what could this actually feature? And these are actually features of non-odontogenic pain, pain that may not be related to teeth or endodontic disease. So on the back of our mind, we need to remember this when we see a patient. And I actually published a paper back in 2020 during the pandemic, actually, about, how to diagnose and how to manage dental pain for medical practitioners. Okay, and this was published in Australian Prescriber, if anyone is interested. So when you see a patient in your dental chair, I think the first point is consider whether there is presence of non-odontogenic pain, besides looking for what is the obvious. This is my second patient that I'd like to discuss. I saw her as an emergency patient, and she was presenting with really severe pain, throbbing pain, for 2 days. And she's been taking ibuprofen and paracetamol. And pain was localized to the left side of her face and triggered by eating and hot drinks and foods. And she said that her problem was actually caused by temporomandibular disorder. I was like, oh, you know this term, how do you know this? And she has actually seen 3 dentists in the past. The first dentist couldn't form a diagnosis, sent her home. A second dentist said that she had maybe parafunction, but she didn't understand what it was. And the third dentist diagnosed her with temporomandibular dysfunction. That was what she remembered. And she said that the problem is in my jaw, not in my tooth. I want to get it fixed because I'm in such severe pain. And this was a patient in her 20s, actually, very young patient. And yes, her left temporomandibular joint was tender, and the muscles around the area was also quite tender to palpation as well. So the question I'd like to ask everyone is, what radiographs would you actually take in this case to diagnose the problem? Because radiographic examination is really important. And what I did was I started with taking a left bite wing. And okay, so I've got the numbering system. I guess, we're all familiar with the FDI system, I hope. Okay, and with the 2.6, you can see some radiolucency underneath the mesial-occlusal composite, and also on the 2.7, you can see a bit of radiolucency underneath there, and the 3.6, you can see some radiolucency on the distal area as well as beneath the mesial-occlusal composite restoration as well. So what I'm looking for on the bite wing here, first of all, is whether there's any caries, whether there's any sort of deficient margins or marginal leakage underneath the restorations, because that could indicate that there's pulpal disease related to these teeth. And I also took periapical radiograph of tooth 2.6 to have a look, since it had, possible secondary caries beneath the restoration. And it was really hard to tell whether the periapical area is healthy, because, there's overlap of the periapical area with the floor of the maxillary sinus. And also it looks quite normal around the periapical area, of the tooth 2.7. I also took a periapical radiograph of the tooth 3.6 as well, and the periapical area appears quite normal. So, what clinical tests would you actually carry out? So these are the clinical tests that I did. I did, percussion, palpation, periodontal probing, mobility, and the cold pulp testing. And with the cold pulp testing, very interestingly, I had a very slow response. But what really helped me to identify the truth was not the percussion or the cold testing, but was actually hot water testing, because she was complaining of having pain, severe pain, with hot drinks and hot foods. So I actually isolated each of the tooth one by one and tested with hot water around the tooth, and that helped me to reproduce her pain and identify the tooth. So I diagnosed tooth 2.6 with irreversible pulpitis with symptomatic apical periodontitis, and also possibly myalgia related to TMD as well. And very interestingly, so after I did the treatment, muscular pain actually disappeared. And it has been actually reported in literature that when a patient presents with pulpitis, it's possible that they can present also with TMD-like symptoms, and that actually goes away after you manage, say, irreversible pulpitis. And also in the paper that I published, patients presenting with reversible pulpitis or irreversible pulpitis, you can also confuse their symptoms with symptoms of maxillary sinusitis as well. So that's something that should be on the back of our mind when we consult a patient presenting with symptoms that's similar to pulpitis. So my second learning point is listen to the patient and reproduce the symptoms if possible to identify the causative tooth. So I'm going on to the third case. And this was a patient in his 30s that was referred for assessment of the tooth 4.6. He had already seen 2 dentists and another endodontist presenting with pain and swelling in his right mandible since September 2022. And the differential diagnosis by the dentist were periodontal lesion or periodontal abscess. So this was a historical radiograph that was sent from the referral dentist. And we can see that there is actually a periapical radiolucency that's quite large, possibly around the root apex of the tooth 3-6, and also even extending to the periapical area around the mesial root of the tooth 3-7 as well. So this is the OPG that was sent by the referral dentist, and you can see very clearly there's quite a large periapical radiolucency that extends across from the periapical area of the tooth 3-6 to the tooth 3-7. And this was, the radiograph by the referral dentist, and then this was the periapical radiograph taken at my consultation. So what clinical, tests would you actually carry out? So in the end, we found that, all of the posterior teeth in the, all the posterior teeth in the fourth quadrant were all responding normally to pulp testing. So it tells us that something else was going on. So I referred this patient promptly to the oromaxillofacial surgeon, and the oromaxillofacial surgeon was really good. He saw the patient promptly and came up with the differential diagnosis of either lymphoma, arterial venous malformations, and osteosarcoma, which are all very serious. And I think that patient was seen very promptly within a week's time. But I think, besides doing the cold pulp testing, the other clue I had, if you look at my periapical radiograph, is that you can actually trace the periodontal ligament space around the roots really clearly in this case, despite seeing the periapical radiolucency. That gave me a clue that maybe this is not actually a lesion of endodontic origin. So do not assume that there is endodontic disease from just a radiograph. It's really important to carry out pulp testing and do the clinical tests. So I'd like to go a little bit into some simple rules with pulp testing, if it's all right with you all. And I think the first step with pulp testing is always communication, because patients don't really understand what they're supposed to feel when you do pulp testing on them. And also I like to test the contralateral and neighboring teeth first. And if the pulp chamber appears patent on the radiograph, I like to stick to cold pulp testing because I generally find that's more accurate. And also if the pulp chamber is calcified and the tooth is not responsive to cold pulp testing, that's when I would try electric pulp testing. Also, with children, we know that, the response may not be reliable, but if I was going to do any pulp testing, I would stick to the use of cold pulp testing. And also bear in mind that, permanent teeth with immature root apex are less likely to respond to electric pulp tests, but seems to have a normal response to cold pulp testing. And also when the patient is undergoing orthodontic treatment, it can actually reduce or eliminate the response to electric pulp tests during and after orthodontic treatment for up to about 9 months. So I just want to show this video.
When we touch the ice on the tooth, I aim for the middle part of the tooth where it's not too cold, and just touch the tooth for about a second or so. Yeah. And when she feels it, she'll lift her hand up. If she's not feeling it, I will actually leave the ice on the tooth for a little bit longer, and I'll actually aim for the top part of the tooth near the gingival margin if she's not feeling it at all. Yeah. So I'm going to test a few more teeth. So I'll get you to open a bit wider.
Okay, so I just want to show this video because I want to explain how I do the cold test as well. I just gently tap the tooth for a second and see whether there's a response. If not, I will leave it on for longer. And if I don't get a response from the more central part of the tooth, I move towards the cervical part of the tooth.
And then when we touch the ice on the tooth,
I'll just move on to the next one. And then with the, I know probably in most clinics, you'll be using something like this.
So we spray a cotton pellet and you can see there's crystals on the pellet itself. And then we're going to do the same. We're going to touch the tooth again, sort of in the middle area, and see if the patient can feel it. Ah, very good. She could sense it straight away. And then we can check another tooth. And you could feel it straight away. Was it uncomfortable at all?
Sharp, but no pain.
Oh, excellent. Good, good.
Okay, I had a very nice patient there, but I'm just explaining where I'll touch the tooth. So, if you have a very anxious patient, it's better to touch the tooth in the middle very gently or more towards the lower part of the tooth or towards the occlusal incisor part of the tooth. But if you have a patient who's not that responsive, then I'll move closer to the cervical region of the tooth.
Spray this.
Sorry, I'll move on forward. Also, we shouldn't forget that, if we feel that the patient can be unreliable, we can do the fake
Then
test.
we actually touch the tooth without the eyes. So did you feel that?
No.
Yeah. So we should always bear in mind that we can always do a fake test if we feel that the patient can be unreliable. Sometimes, even if you do the spray test, you can tell your assistant spray somewhere else and then, do the test on the patient. And that's a good way to tell if the patient is.
And then we actually.
So I'm going to move on to case number 4, Mr. MM. So this is a patient in his late 20s, and he was referred for the endodontic assessment of tooth 1-1. And then patient has been getting some, an episode of dull pain localized on the tooth, and he's worried about the discoloration of the tooth. And about 10 years ago, he fell on concrete ground, and then he chipped his front tooth, and subsequently he left it and then saw a dentist a year later. So this was my patient. So I took some photos of him. You can obviously see the discoloration on his front tooth, tooth 1-1, and he was quite concerned about it. But if you look at the photo, what do you notice about his neighboring teeth? Do you notice another discolored tooth? So I certainly noticed that there was another discolored tooth, which is the 4-2. So I took radiographs of the 4-2 as well, and I can see a periapical radiolucency around the root apex of the tooth 4-2 as well. And when I did the pulp testing, I was quite surprised, but I got a negative result for the teeth 1-2, 1-1, and 4-2 as well. So my diagnosis were tooth 1-2 necrotic pulp with normal apical tissues, teeth 1-1 and 4-2 with necrotic pulp, and asymptomatic apical periodontitis with external inflammatory root resorption. So this was, pre-op and post-op treatments, and then we completed his treatment for the 4-2 as well. And then we did internal bleaching for both the 1-1 and 4-2 as well. And I guess, the takeaway learning point for this case is that, for a patient with a history of dental trauma, don't just assume, that there's just one tooth being affected from the incident. Always assess all the maxillary and mandibular teeth, anterior teeth in the affected region. So it's worthwhile looking a bit deeper, figuring out if there was any indirect trauma on other teeth as well. So I'm going to go on to my case number 5. This was a patient who is 17 years old, and she was referred for pain diagnosis and continuation of endodontic treatment as the dentist couldn't negotiate the mesial root canals. Okay, so maybe it was because the root canals were very narrow or calcified or ledge, potentially. And she has been having an episode of throbbing pain, which was exacerbated by biting, and her sleep was affected, and the patient was given a course of antibiotics, okay, by her dentist. And she was aware of clenching, and she feels quite stressed about her upcoming exams. So during examination, so transillumination was used, and there was no obvious clinical indication of occlusal wear, but multiple teeth have crease lines. So there were clinical tests being carried out, and the 236 had a negative result, which was kind of expected. But a periapical radiograph was taken. And what do you think is going on there, because it seems a little bit unusual looking at the periapical radiograph that there is actually a radiolucency on the lateral surface of the root in the mid-root region. And also there was another periapical radiolucency around the mesial root apex, maybe extending to the area around the distal root apex. But why is there a radiolucency in the mid-root region next lateral to the mesial root? That's a little bit unusual. So a CBCT scan was taken, and that allowed us to see that there was actually an oblique horizontal root fracture in the mesial root, which explains why there is actually a lateral radiolucency. And that was really interesting. And I guess, with teeth with cracks or with vertical root fracture, sometimes with the, with the CBCT scan, it actually can allow us to see, the defect or the bone loss pattern on the side of the roots, which gives us a little bit more clue to whether there's a crack or vertical root fracture. And you can actually look at the bone loss pattern to determine whether there's a cracked tooth or potentially a VRF. And this was actually quite a good paper to look into it if you want to read more about it. And it actually tells us that, teeth with vertical root fracture have deeper probing depths usually than cracked teeth. And also teeth with vertical root fracture will usually associated with teeth with indirect restorations, where teeth with cracks generally with direct restorations and shallow probing depths. Okay, so I'll go on. So I think the learning point to take away from this is to confirm the etiology, and a limited field of view CBCT scan can be quite useful in cases when 2D radiographs do not provide, adequate information. I'll go on to my next patient, who is Dr. KP. So Dr. KB, she referred herself to me. She's a dentist herself, and she has been having constant throbbing pain on tooth 1 tooth for a week. And pain was exacerbated when she was biting on the tooth and when she was lying on the right side of her face. And from the examination, she definitely had some tenderness when I palpated the muscles of mastication on the right side. And with the test that I carry out, tooth 1, 2 was tender to palpation and percussion, and also it had a negative response to the cold pulp testing. So this was a periapical radiograph taken of the tooth, which looks quite unusual. As you can see that, there is actually a dense invaginatus within the tooth itself, because if you look at the center of the tooth, you can see this enamel invagination within the tooth into like a diamond-shaped space, and that extends down towards the apical foramen area. And this was a CBCT scan that I took of the tooth. Oops, sorry. So this is a CBCT scan I took of the tooth. I'm going to play it if I can. Okay. So when we look at the scan itself, what's really interesting is that with the dense invaginatus, it looks like it's more sort of buccally positioned. And then you have a C-shaped canal space in the palatal area, which looks a little bit unusual. Yeah. Okay, so I'm going to go on to this. So my diagnosis for tooth 1, 2 was a necrotic pulp and symptomatic apical periodontitis with dense invaginatus type 3B. So there was a researcher called Olas. He Yes. So the diagnosis for this tooth was dense invaginatus type 3B. And you can see that in this type of cases, the dents actually extend all the way down to the apical foramen alongside the root canal, and it's usually separate from the root canal itself. and she might have myalgia related to bruxism as well. So we decided to proceed with endodontic treatment. Now, endodontic treatment was quite challenging because, first of all, I had to actually access through the dents, which is, surrounded by enamel. And then I have to locate, where the dents actually, lead down towards after going through this diamond-shaped space. Sometimes when we put a hand file into an irregular space like that, if your hand file was curved, it may be hitting along the side and may be hard to trace the pathway of the dents. Also, locating the root canal can be challenging. So using a limited field of view CBCT scan can be very useful in terms of providing us with a map for treatment. So I definitely find it helpful when I'm carrying out endodontic treatment of teeth with complex morphology to use a CBCT scan in such cases. So I'm going to go on to case number 7. And this was a 40-year-old patient referred to me by a prosthodontist. And he has been experiencing intermittent pain and swelling for many weeks near tooth 2. And he was asymptomatic at the consultation. And he's been prescribed antibiotics by the dentist around a week ago. And his anterior teeth were restored with crowns by a prosthodontist around 3 years ago. So he had a history of seeing a periodontist for many, many years, and he's undergoing maintenance with the periodontist. So this is how he presented, and this was my periapical radiograph taken at the consultation. My diagnosis for tooth 2 was a necrotic pulp with chronic apical abscess with external inflammatory root resorption. And there was a 10 millimeter periodontal pocket on the distal palatal surface. Now, this looks like, it could be a perioendal lesion. And I couldn't detect any cracks around the side of the root when I inspected it under the microscope. I push away as much of the gingival tissues as possible to have a good look. And now, the question I want to pose to everyone is, would you consider, extraction of this tooth, or would you consider treating this tooth? I think a lot of people might hesitate treating this tooth because of the appearance of the radiolucency being like a J shape and large periapical radiolucency around the root and the swelling that they can see. So I posed this question on Instagram, and surprisingly, I was happy to see that most people were happy to save it. So when we look at the AAE classification of periodontal diseases, I think most of the time we worry that this is a combined pulpal and periodontal lesion in which the two independent disease processes have joined in the periapical tissues, because that means that the prognosis is a lot worse. But we never really know whether it joins or not unless we actually carry out some treatment. So in the end, I carry out treatments, and then I said to him, let's start the treatment and see how you go. But of course, it's a little bit uncertain, but let's give it a go and get you back in maybe 6 months' time and have a look. This is what I saw in 6 months' time. And then this is what I saw on the radiograph after 1.5 years, after treating him. So in this kind of cases where you feel that prognosis, may be a bit uncertain, I think it's reasonable to offer patients the option of starting treatment first and seeing how it goes. And recently in Australia, there was a paper published in 2024 by Wong et al. And they found that, we definitely look at things like bone loss extending to the apical third, probing depths of 5 to 7 millimeters, and history of no periodontal disease to tell us whether, whether the prognosis is likely going to be good or poor. But we obviously have to select our patient very carefully and also discuss the risk of losing the tooth. And if the patient is willing to start treatment and see how it goes, then, we can maybe perhaps determine the prognosis a lot better after initiation of endodontic treatment and giving it a bit of time to see the healing process. So I'm going to go on to case number 8. And this was a patient in her 40s who was referred for multiple teeth 3, 5, 4, 3, 4, 4, and 4, 5 from her periodontist. She had already experienced 2 episodes of severe throbbing pain since September 2020. And she was frustrated because she was told by several dentists and endodontists in the past there were no issues with her teeth. And then recently then informed by her periodontist that she needs to see me. And she had a history of orthodontic treatment and also bruxism. And she has a history of severe anxiety with dental treatment as well. So she saw a dentist in 2020 because she was experiencing a soft tissue swelling under the tongue. And there was no swelling noted by the dentist. And the dentist thought maybe she had caries and pulpitis on tooth 4, and maybe she had a cellular leaf. So he was going to refer her to an oral medicine specialist. And then this was the radiographs that was taken by the dentist. Okay, so obviously you can see that the dentist may have a lot of difficulty getting the radiographs because he couldn't capture the periapical areas, of the tooth 4. So what would you actually consider doing next in such a situation? The patient then ended up being referred to another endodontist, and the patient was diagnosed with bruxism. And the endodontist at the time thought that they might have been occlusal trauma on tooth 4. And then another dentist then restored tooth 4 with a distal restoration. But looking at the radiograph again, taken by the dentist, do you notice something really unusual there? So one of the things I want to look at is the location where she has this sort of notch like area on the side of the tooth. And when we actually look at the OPG as well, you can see those notches on the side of the tooth in the cervical area on several teeth in the posterior teeth, premolars, in the mandibular areas. And also you can see periapical radiolucencies associated with multiple teeth. So in her, at the consultation that she had with me, her pain was exacerbated by, pressure on tooth 4 and having warm or hot drinks. And these are the periapical radiographs that I took. And it was really, really challenging to get the radiographs because the patient was extremely nervous. So it took a lot of communication as to what she would expect. And also I had to really get her to feel comfortable with me in my care, and also put a bit of salt on her tongue to distract her from, having a gag reflex. Before I could get the radiographs taken. But you can see obvious periapical radiolucencies around the root apices of teeth 4, 4, and also 4, 5. And also around the root apex of the tooth 3, 5. But also notice the unusual radiolucency on the side of the roots there in the cervical region, like a notch on the side of the root. And there's also a restoration that was placed there. So with all the pulp testing that I did, the teeth 3, 4, 4, and 4, 5 had all negative response to pulp testing. So all these teeth had necrotic pulps, and tooth 4 actually responded positively to electric pulp testing. So that had told me that the pulp of that tooth is actually vital. So with teeth 3, 5, 4, 3, and 4, 5, they had necrotic pulps with asymptomatic apical periodontitis, but tooth 4 had normal pulp, and it didn't respond to the cold test because of the pulp canal calcification and had normal apical tissues. So, but going back to the question, what is actually the etiology? What could have caused the pulp to become necrotic? One of the reasons is that this patient was extremely diligent with using interdental brushes, And I think with the technique of using the interdental brushes, because it has the metal wire in the middle of it, she was actually scraping the metal wire really hard against the side of the root of her teeth, which could have caused those notches to form on the side of the root, and that could allow for bacterial ingress with time. The other thing too is that, you know, with the pulp canal calcification, she could potentially had some occlusal trauma on that tooth in the past, or some form of trauma or repair process to movement of her teeth during orthodontic treatment as well. So I think that we need to realize that in some patients, taking diagnostic periapical radiographs can be very challenging. And always consider the etiology of why patient has ended up with, you know, a tooth with a necrotic pulp. So going back to my last point in the presentation, you know, I think it's important to understand why you should consider specialist referral. These are some diagrams I pick out from internet. And obviously, you know, we don't expect normally to see roots that look like the Running Man or roots that have like nearly a 360-degree curve. So I would say that, you know, it's very rare that we encounter those cases. But I think that we also have to think about factors that you need to actually consider before you decide to refer. For example, you should ask yourself some of these questions. First of all, do you feel stressed about forming the diagnosis or treatment process? Are we actually giving patients all the treatment alternatives, including consulting a specialist as an option? And also, do you think that the treatment plan could be provided by an interdisciplinary specialist team for the best interest for the patient? For example, if I were to manage a patient, a young patient, for you know, management of dental trauma, I'll be thinking about whether the child would need to be under the care of a pediatric specialist, and whether the child may need to see an orthodontist as well if the teeth were not aligned well, and the occlusion needs to be adjusted, or whether the patient needs to see a prosthodontist in the future if there was a need for replacement of teeth, or a need to improve the appearance of the patient's teeth as well, aesthetically. So those are questions that will come up in my mind, you know, even for me as an endodontist, that I cannot do everything myself, and I may need to refer to other specialists as well. And also, have you spent an appointment not achieving any further with your treatment? So in my training, I used to remember being told as, you know, as a specialist in training, that if you are carrying out endodontic treatment on a patient and you're not making any progress in 10, 15 minutes, it's time for you to think about doing something else, something different to make a difference. And also, have you discussed any potential controversies with your patient? If your patient has a different opinion to you, you know, have you discussed it through to give your patient informed consent? And also, can you provide the patient with a reasonable level of disclosure? And there are actually resources out there, fortunately, to help us to determine what the case difficulty is. And I like to use the one by the American Association of Endodontists. And it even has like a phone app you can download that will walk you through, you know, the determining the case difficulty for your patients. And determining case difficulty is important because obviously it can actually increase your risk of having mishaps, or increase the time you spend with the patient, because you might be spending a lot more time with the number of visits with the patient. It can potentially change the course of your treatment and outcome. So for example, you might start treatment on a tooth and you realize this was too challenging, and then you need to refer. That can then change your treatment and outcome. And also, if you recognize the cases that you can manage and the cases you can't, then it reduces your risk of patient complaints and dental legal issues as well. So it can inform the patient of the risks and complications that might be lying ahead. For example, if you manage a tooth with really calcified root canals, and then you end up with a file fracture, or you end up, you know, creating a ledge, at least, you know, your patient is well informed that, you know, with the case difficulty, it will require potentially a referral to an endodontist. So with the form from the AAE, it actually classifies, you know, the difficulties into patient considerations and tooth factors and other factors as well. But with the medical history, obviously we are looking at patients with complex medical history, whether the patient is hard to numb up, also whether the patient is compliant, whether the patient has a small mouth opening or has trismus, and we consider whether the patient has gag reflex and whether the patient is in severe pain or not. But what the form doesn't include is these kind of other patient considerations, because sometimes we have patients that come in with really unique personalities, and they may complain about the previous dentist and can be mistrustful and paranoid. Some patients can be quite demanding, and you know, they will actually have drug-seeking behavior, or they might be OCD about the tooth, and they keep touching the tooth and say, oh, I keep feeling pain there every day, you know, even though you reassure them. And also they might think that they shouldn't be feeling any pain at all after endodontic treatment, and think that if there's pain after endodontic treatment, there must be something wrong. Or they might actually be extremely concerned about a risk of complication as well, or risk. For example, I once had a patient who said to me, can you guarantee that I will not die from root canal treatment? And I said to the patient, of course, theoretically, everyone could die from root canal treatment, but the risk is so low that, you know, it's going to be really, really rare for that to even happen. And I said that if there was an earthquake here and if the roof collapsed, we will both die. So, you know, we can't prevent every risk of complication, or even a patient who threatens to sue you. Those are situations where we have to think seriously, do we want to actually see such patients? And of course, there's also other factors like whether you can form a diagnosis and having difficulty with taking a radiograph, as shown in my last case, position of the tooth, whether you can isolate the tooth properly, and whether the root canals are calcified, very narrow, whether they are very curved, or proximity to vital structures like the mental foramen or even the inferior alveolar nerve. Whether there's root resorptions that can make it really challenging to clean the root canal well, and also place a root filling. And of course, we also have to think about the history of the trauma, whether the patient has gone through endodontic treatment before. And I always like to ask the patient, if the patient had gone through endodontic treatment before, what was your experience like? Was there any part of the treatment that you found difficult, or was there anything that you felt that the dentist could have done better for you? So I always ask them these questions to get an idea of, you know, how they feel about endodontic treatment in general. And some patients would tell you they hate this or hate that. You know, then you try to find a solution with them, or they'll say, I really worry about feeling pain during endodontic treatment. Then you probably want to actually consider supplementary local anesthesia techniques. And also patients with periodontal or endodontic condition, that might impact on your treatment plan with the patient. For example, the patient I shown, where I started the endodontic treatment, I left it for 6 months, then got the patient back to see what the healing looks like. So to summarize, I think we need to have a well-documented diagnosis and restorative plan before proceeding with the treatment. And we should never initiate root canal treatment simply based on radiographic findings, such as the presence of a periapical radiolucency. And we need to inform the patient of the diagnosis, case difficulty level, and also of the relevant complications and risk before proceeding. And always provide the patient with options for specialist referral. Thank you. And because tomorrow is International Women's Day, I'd like to wish all the women that are attending this webinar and all the women watching this webinar a wonderful day tomorrow. And yeah, then thank you for staying for my webinar. I really appreciate it.
Many thanks, dear Ovana. Very interesting, amazing, insightful lecture from you. Happy International Days to you, and also to Dr. Parisa. It's a great pleasure to have you as our members, and we know that the women endodontists are also very good, and they are amazing, and it's a great chance to have you with us. Thank you. I just want to start from Dr. Parisa to start her question or anything that she want to ask you, and then we will go to Dr. Al-Atta. Dr. Al-Atta, can you hear me? If you can turn on your video, we will start the conversation.
Hello, everyone. Yes, I'm here.
Thank you. Okay, we will start with
Hi.
Dr. Parisa.
Hi. Hi, everyone. It was really amazing, dear doctor. Oh, Anna, really, I had a very good time because you told really exactly about diagnosis with a lot of cases that I think it's really challenging. You know, pain is really a big factor, and I really want to know that people that come, I mean, patients that come to our dental office always are telling that we have pain, we have a problem. And you told us
Oh, I think we have missed Dr. Parisa's voice. Yeah, she will join again, no problem.
Okay.
Let's wait, yeah. If she's going to join us again, yeah. Dr. Parisa, can you hear me? We have lost your voice. Okay, no problem. I want to ask Dr. Atta to start his questions. And if you have any question, if you have any comment, please feel free, my friend.
First of all, thanks, Dr. Ovana, for the insightful lecture. We really enjoyed it. You went systematically with everything that everyone needs for diagnosis. However, I'm not sure if I missed this point or if you didn't mention it. I need to ask about the relationship of mobility with pulpal diagnosis. Like, I've attended one of the lectures 2 years ago for a well-known doctor here in the Middle East, talking about that. We go systematically for the pulpal diagnosis, then for the periradicular diagnosis, and if we are having multiple teeth that are having the similar signs and symptoms with the patient, we can rely on the mobility. I'm not sure if there is something in the literature talking about such a thing, but since we are talking about diagnosis and about prognosis today, I wanted just to bring this point up. And I'm not sure if you are familiar of mobility of teeth with the pulpal diagnosis.
So when I think of mobility, it's just one of the clinical tests that we carry out. Like, for example, when we examine a tooth, we want to know if the tooth is mobile or if, the restoration on the tooth is mobile. Sometimes, for example, if we are looking at a split tooth, the tooth fragment will move apart when you do the mobility test. So in those cases, we would assume that the pulp is already necrotic by that stage, right? And that we know the diagnosis is hopeless. So then it's like there's no point even to actually form a pulpal diagnosis in such a situation. But then, when we also look at mobility of the tooth itself, it tells us, for example, if potentially the tooth could be mobile because of, say, dental trauma. The patient had trauma and the tooth was luxated, the tooth mobility then increases. It may not give us much information about the pulpal diagnosis because, when a tooth is traumatized from an accident, the blood supply could be affected. And then that the nerve supply. So doing the pulpal diagnosis is probably no point at the time of the accident. And I think, in situations where I actually examine the mobility, I think about also whether the tooth has periodontal disease. And also, if there's a lot of support, if it's a class 3 mobility where the tooth is mobile, laterally and also vertically, maybe the prognosis is too poor for us to actually, consider endodontic treatment in those situations. So maybe I think it relates more to prognosis rather than pulpal diagnosis.
Perfect. Thank you very much.
No problems. Yeah.
Sorry, guys, my internet was disconnected. I was asking a really, I have a question. I want to know, in your private office, do you have a team? Or, because you told me that in one of your cases, I think you had a connection with maxillofacial surgeon, and in your group, I noticed that maybe a pathologist or maybe a person that is an expert in medical, diseases. Because I think in these cases, maybe teamwork really helps us. I want to know specifically in your clinic, do you work with other specialists, or
Yeah,
no? It's
I'm
you
very
refer to other places.
Yeah, so I'm
You
very fortunate. I work in a practice right in the center of the Melbourne city, and I work with specialists in all other different disciplines in one practice. And I could see a patient and then have the patient see a prosthodontist next door to my room. So it's pretty convenient, and patients don't have to travel far from one place to another. And then I can discuss the case directly with the other specialists as well, which makes it so much more convenient. And it's always interesting to hear the perspectives from other specialists in different disciplines on how differently they see things. And to gain a perspective of treatment options that could be offered to the patient as well. And I think that's definitely a big plus in where I work in.
Yeah, because really the patient will be really, it's easy when you can refer it just next door, not, I mean, even sometimes when the patient wants to go somewhere else, um, it's a big factor for the patient. And I have another question about one of your cases. I was asking that question, then my internet got really poor. I had a poor connection. You told us that in one of the cases, I think you had a huge lesion, and but you told us that in a lot of cases, maybe it's not an endodontic origin, and maybe the disease is coming up from somewhere else. I want to know that in these cases, when you want to refer to other specialists, what's the first because in Iran we have like a fellow in pain, a fellowship in pain. I want to know, in Australia, do you have some specialists that you can refer them in the first stage, and then, I mean, refer to other specialists? When you want to refer, who's the first person in these kinds of cases with huge lesions that you notice it's not endodontic?
Yeah, so I think that with very large periapical lesions in the jaw, and if we know that it's not related to, say, a pulpal or periapical disease, then we need to consider referral to an oromaxillofacial surgeon, because they are the ones who will
Is,
do both.
is it the first choice, or other specialists? You send it first to our maxillofacial surgeon. Mm.
Yeah, because unless it's just a soft tissue swelling or soft tissue lesion, then we will refer to like a oral medicine specialist in Australia. Because most, for example, if there's a jaw lesion and it requires a biopsy or surgery, I don't think that oral medicine specialists would do that in their clinic. Yeah,
Okay, thanks.
no problem. Thank you for the question.
Many thanks for your conversation and the questions. I think we have also some guests from different countries here. I want to ask all the participants if they have any question or have any comments, they are free to ask, and then I will go for my question, if you can allow me. If there is any question, everyone can start and open their microphone, and then they can ask their questions. If there is any question. I will ask a few moments and then I will go for the final part. Okay, it seems that there is no other question. Okay, dear Avan, I want to ask you some of my question about your cases and about your concepts. I want to know if you go for any cavity test. As you know, we have cavity tests in the cases that we don't know the exact source of and the site of the pain, and we can go for cavity tests. But there are some controversies about the cavity test. Some may say that because we have good devices and we have good pulpal tests, nowadays we cannot go for cavity test, but at least in my practice, I do cavity test because it's a good choice for see that if the pulp is necrotic or is vital. I want to know your concept and your idea about cavity test.
Personally, I have only done one cavity test in my whole life. So I haven't done cavity test on the routine because I found that maybe it's because I generally see a lot of really super anxious patients. If I was even going to touch their tooth with the triplex air, I think they would jump out from the chair.
Yeah, the false
So,
negative results are very high.
yeah, so
False
I think,
positivity.
yeah, but I feel that with my patients, it would be probably all positive because they will be too anxious, with the test cavity test. So I don't really like using these tests on my patients. Yeah.
Very good, thank you.
No
And
problem.
about detecting the cracked tooth, yeah, and about the detecting cracked tooth syndrome, because the cracked tooth syndrome is challenging, actually, diagnosis. And I want the algorithm and the steps that you choose to find cracked tooth syndrome. Is it possible to find and detect these cases very soon, or we just say that we will find them and diagnose them at the final stage? I want to know about your concept.
Generally, I find that dentists would refer these patients to me when they have difficulty in forming a diagnosis, first of all. And also, usually they will have seen some indication of a crack line on the surface of the tooth before referring. So, for example, there are some sort of indications where the tooth could potentially have a crack. Like, say, for example, if the pulp became irreversibly inflamed or inflamed because there was actually just even a shallow restoration being placed on the tooth. And then the patient keeps having pain to biting or keeps having sensitivity to cold, even though the dentist has restored the tooth really well. And the dentist might be figuring out like what is going on. Maybe there's a crack inside the tooth. That's why the patient is having these persistent symptoms. So that's, one thing that I look for. And the other thing too is that obviously the sooner we can pick up on, whether there's a crack or not, it is always going to be better in terms of outcome for the patient. For example, in the clinic that I work in, we use transillumination to check for cracks. And also if we pick up that there is actually a crack on the tooth and say the patient has reversible pulpitis, we can suggest, maybe like a composite resin overlay restoration on the tooth to see how the symptoms go. And if the symptoms become worse with time, then, obviously then we can consider endodontic treatment. And then when we actually do the endodontic treatment, we can assess internally with the microscope, how deep the crack has extended into the tooth. So obviously the earlier we can pick up on this, the better it is, because the deeper the crack or the more extensive the crack, obviously it's going to affect the prognosis of the tooth. And also, I find that, a lot of general dentists really struggle with forming a diagnosis first and confirming whether there is the presence of a crack or not.
Very good, thank you. And I
Do
want
you find that in your
to
practice as
ask you.
well? Sorry, do you find that in your
Yeah.
practice as well? Like, do you find that dentists have a lot of trouble with managing cracked tooth?
Yeah, we have the same issues because we are the last specialists that face the challenge. They go for different dentists, for different specialists, and they were suspected about the different sources of pain. But finally, we see that the source of the pain was because about the cracked tooth, and we have the challenge in our country, and I know it's a universal challenge. Yeah, but for my idea, the main sign and symptom is that we have a large restoration without reaching to the pulpal area, but we see that the patient is complaining about, for example, pain on percussion, pain on palpation, and pain on chewing, and also about the cold test and the hot test that we see that the pain is responding very aggressively and very high to the such a sensibility test. And then I will suspect about the cracked tooth syndrome. I will remove the restoration and I will check the area and the tooth under the magnification. And based on the articles, the magnification and using, for example, methylene blue and other dyes will help you to find those cracks. And yeah.
Definitely. And also we consider if the patient has a history of bruxism. In some of these cases I've seen, like the tooth hasn't even had a restoration on the tooth, like say even the maxillary premolars. And if the patient had severe bruxism, sometimes there's a crack already there without even the tooth being restored in the past.
Yeah, exactly. I was very amazed about the cases that you shared. The VRF was happened at the tooth without any endodontic treatment and without any coronal rod large restoration. And that was very amazing. Can you define us the etiology behind that? Is there related to the anatomical variations that we have? But I want to know your idea about that finding.
Yeah, it is possible. The tooth has been restored in the past, and it's possible that, you know, maybe there has been occlusal trauma on the tooth, potentially after the tooth has been restored. Also, the patient has been going through quite a lot of stress, so there is definitely bruxism as well that could be contributory to the cause. But that was a really unusual case, and that's why I wanted to show it.
Yeah, that was a very unusual case, but very interesting. And we have to consider that because ordering CBCT and having a full steps of diagnosis and treatment planning is very important because we don't want to do a mistreatment. You know, a good treatment for a wrong diagnosis is not acceptable and it is a mishap.
Definitely. And I think that also not everyone has accessibility to the CBCT scan as well. And in this kind of cases, it can be quite tricky because if you don't have access to a CBCT scan, then, you know, as an endodontist, you'll be going into it without realizing exactly what is going on.
Yeah, that's the main problem, I think, in the world, because CBCT is not considered as the initial modality of choice, but it's very important because it will change the treatment and diagnosis. And it's very important to consider CBCT, and we have joint position statement about ordering CBCT.
Definitely.
And now, do you agree? A lot of dentists, even general dentists, order CBCT because it really is a main factor.
Yes, it is getting quite common in Australia. But the type of CBCT scans they take sometimes may not be of high enough resolution to be really helpful for us sometimes. And in Australia here, if a patient gets referred by a specialist to get a CBCT scan done, they actually get some, like subsidy from the government in terms of costs for the CBCT scan.
Interesting.
Yeah, but if they do it with a dentist, they don't get any subsidy. So maybe patients are a little bit more deterred in getting those CBCT scans done just with the general dentist. But of course, you know, you're going to have some practices that would take a CBCT for every patient they see. And there are some practices that don't do that. But I think for us, you know, we can only control what we do as specialists. for our patients. And, with the use of CBCT scans, I would say that in Australia in general, most endodontists are still a little bit conservative compared to a lot of countries. And I think that we definitely look at something unusual before we decide whether we're going to use it or not. But the use in general is increasing around the world, I think. Would you agree? Yeah.
Yes, I agree. And I think one of the other challenges that we have is really that, everybody, like I'm an endodontist, I just want to do my root canal treatment and I don't even care what's going on. The patient tells me like a tooth number two has a pain. And I say, okay, this latter has a problem and I just want to treat it really quickly. And I don't even care about what's going on. But if we really focus on palpation, percussion, and vitality tests, everything will be changed. But after the treatment is done, everybody comes to us with a pain, and then we are thinking about what was going on. But if we first think about the diagnosis and then do the treatment, it will be really everything will be more successfully, and we will have a better result. Then diagnosis is really a main factor in all of our treatment, in whatever our specialty is really is. You told us really a lot of I think points that it is useful for general dentists, and even for the students that are just learning and are in the first steps.
Yes, I think I think with these cases, I just wanted to demonstrate the few points I've shared, and hopefully people will take away from it and be able to apply that in their practice tomorrow.
Yeah, very
Exactly.
good points and very
useful.
tricky points. Thank you. And
problem.
I have also another question about the endoperio lesions. I want to know your concept because there is a dilemma between save or extract, and some wants to go for extraction because nowadays implants are very spreading worldwide, and it's an alternative choice for such situations. But I want to know your concept about such cases. Do you suggest your patients that we can start the treatment and we will check the initial response to the treatment and then we will go for the implant? But some may say that it is not cost benefit because the patient have to spend money to check the initial the result of the initial treatment, and then that's the actually issue that we have to consider. I want to know how you manage your patient in such cases about saving or extracting, and how you go for that.
Definitely. So I think it's getting more common that people nowadays would give up on teeth and go for implant therapy. But the more we know about implant therapy, the more we realize that there are actually a higher percentage of complications, even though then compared to say doing endodontic treatment. And with these implant complications, sometimes to manage it, like say peri-implantitis, is not always predictable. And we have to think of endodontic treatment as an implant treatment as comparing apples and oranges. They're two very different treatment modality. Okay, I always explain to patient, if we try endodontic treatment, we're working within the confines of the tooth and the root, and you have less complications. And we know that there's a lot of literature saying that we can actually retain or most teeth with that has gone through endodontic treatment is going to survive long term. But obviously we have to assess each tooth individually with all the prognostic factors. And I guess also it comes down to communication with the patient on what their expectations or what their wants are. And we certainly have patients that will try to save their teeth at all costs. We have patients who are not very keen on saving their teeth because of financial concerns, for example. So I think it comes down to also communicating with them. Are they willing to take that chance to save their teeth, because if you don't save the tooth, the only option is to extract it, and then the tooth is gone. And if you try to retain the tooth, the other benefits of doing so, if there's actually regeneration of the bone around the root apex, is that down the track, for example, you may not actually need as much, like say, complicated bone grafting procedures if you wish to have an implant as well. So that's something that we also consider when discussing with the patient. And if the patient is still keen for implant therapy or extraction of the tooth, I even say to them, look, you can always consult an implant specialist, get the opinion of an implant specialist, have a decision about whether you can actually have implant therapy or not, because some patients are not suitable for it. And then before they decide to come back to see me to do the endodontic treatment. And by that time, when they decide to see me, I know that they already understand in their mind, they've looked through all the options, and then they really set their mind on having the endodontic treatment and are willing to bear the risk, if the endodontic treatment doesn't work out. And I only charge half of my fees when I carry out the first part of the treatment. I say to them, look, if it doesn't work, you are only charged half of the fee. And then, at least we give it a try, and see what happens. And we want people who are motivated to save that as well, right?
Yeah, exactly.
You are a savior. You are really an endodontist that likes to save tooth.
I think, we have to recognize that there are some patients that can see the value in saving their teeth, and there are some that just can't, as well. We also have to understand their expectations and what they want and what they need. Yeah.
Okay, what is your idea, Doctor, about saving or extracting, and about heroic actions? Because I am a fan of heroic actions in some cases to save the tooth, but heroic actions are considered not based on articles and literatures, because we have experience of having endodontic treatment on many cases that we may say it is hopeless, but we do the treatment and we will see that the tooth is surviving for many years.
For me, heroic actions actually depends on the patient himself or herself. Yani, if the patient understands, as long as the patient understands what they are paying for, what the risk that we are taking, we are taking a certain risk of either saving or losing the tooth. But for me, I like this risk. If the patient is understanding that I'm doing this for her own or his own benefit, then I don't mind it. We can go for it. And as you said, sometimes we cannot only base on literature. Sometimes our clinical experience can play a major role in such situations.
I definitely think that it comes down to case selection, and whether the patient is also willing to take that risk with you and fully understands it.
Yeah, for sure. It's case selection at the end, yes, as you said. And for me, the main factor is the patient. The patient, some tiring patient, as we can say, might say that I don't want to pay this amount of money for nothing or to lose the tooth at the end. So the main factor for me is that I explain the patient everything and I make sure that he or she understands every single step that we are doing, and we might do it for nothing at the end.
Very good, very good.
But a lot of patients around us love to save their tooth, their natural tooth, and they really reject implants, the surgery, and they think that it's a foreign body. Maybe it's something that it's not their own thing. But at the end, the prognosis, the years that the tooth wants to be in the mouth is.
Oh, we have lost Dr. Parisa's voice, I think, yeah. Okay, I want to point out some points about the implant and the endodontic treatment. I think getting back to the function for the endodontic treatment is very fast. I always tell my patients, and if you want to do any implant treatment, you have to wait at least for 4 or 3 months to get back to the function and use that implant. But for the endodontic treatment, it is very easy and fast. And also we have some articles about the second implant placement. The success rate will decrease very because the secondary implant placement is much risky and it's much lower. If we lost the implant, we don't have any other options. But if we lost the tooth, we still have the implant placement options. And also about, I think about the complication, as Dr. Awana mentioned, I have seen many patients that have the experience of having implant, and if they want to do the implant treatment again, they will tell me that I am eager to keep my tooth as much as possible because they have passed such complications and such issues about restoring their tooth. And they say that I'm eager to have my teeth as much as possible, and then I will go for implant placement. And I think these are very important to be considered.
I totally agree.
Yeah. Okay. We are reaching the final parts of the discussion. We have passed about 1 hour and a half, and it was very interesting and very insightful discussion. Thanks for all you, to Dr. Awana as the main speaker. It's a great pleasure to have you. Very insightful, very amazing lecture, and we have learned a lot. Learned a lot, and we have learned many good points and tips, and we have to consider them in our daily practice to have a better diagnosis and treatment planning for our patients. And every good treatment starts with a good diagnosis, and you have taught us those points that they can help us. Thanks to Dr. Al-Atta and also to Dr. Parisa for coming here and for giving us your knowledge and your experiences. It's a very honor and generosity that you share your knowledge and experiences without any expectation. Okay, I want to finalize the discussion. Dr. Awana, if you have any comments and if you have any final words, we are all ears, and then we will finish this session.
Thank you all very much for inviting to Rita's show. It was quite a surprise for me, but I really enjoyed connecting with you all, and hopefully we will get to meet in person one day. And we also have a very major endodontic meeting in Sydney next year. It's the IFIA endodontic meeting. So if you can come to Australia, please let me know. I'll be happy to sort of meet you there in Sydney. So yeah.
Thank you for sure. We want to meet you in person and face to face, and we will find the chance. And the Endo Leader is going to hold programs, and I think Sydney can be a good city and place to hold also Endo Leader Show lectures, seminars, and we are looking forward to meeting you very soon. And we will invite you for the future events about the Endo Leader Show, and we will be very happy and pleased to have you besides us, because Endo Leader Show is a good platform for sharing and spreading such knowledges, and having Endo leaders, members like you, it's a very good chance, and it's very valuable to have you. Thanks for your attention to all the participants, and we are looking forward to meeting you for the future events. Have a good day and have a good time at your countries.
Thank you.
Thank you
Thanks,
very much.
everybody.
Thank you.
Farewell, my friend. Farewell, my friend.
We had a very good time.
Good time.